My name's Darren Milet. I'm joined today by Nicolo Piazza from McGill. And we're here today to discuss a manuscript in EuroIntervention by the Burn Group, and in particular the first author, Stefan Stortecki, regarding different modalities for TAVI sizing. Nick, you wrote an editorial in this manuscript. Perhaps you'd discuss with us the salient findings.
Sure. This was a single center study that evaluated approximately 170 patients. Part of it was retrospective, part of it was prospectively performed. And they basically looked at three types of imaging modalities to assess the aortic annulus for transcatheter valve sizing. They looked at angiography, they looked at echocardiography, and they looked at CT scans. And they then had two blind physicians assess the aortic annuli across these imaging modalities and then perform some analyses.
Okay. The different parameters they used, you said CT, angiography. The echocardiography was both 3D and two-dimensional?
It was transesophageal 2D.
Transesophageal 2D, okay. And tell us what they found.
Yeah, so they, at first they just looked at what type of measurements they obtained. And when you look at this, a lot of the findings in this manuscript confirm what other publications have found. Namely that, and maybe before we go into the results, maybe we just should step back and try to understand very quickly what we're actually measuring with respect to the aortic annulus. So the aortic annulus is defined by the basal attachment points of the aortic valve leaflets. It's a virtual ring, as the paper describes. And depending on how you look at the annulus, you may appreciate different measurements because the annulus is not a perfect circle. And on top of that, with each of these imaging modalities, you don't necessarily cut through the center, the geometric center of this shape. And therefore, you may, from one view, you may get a certain maximum diameter. From a different view, you might get a minimum diameter. And all of these imaging modalities all have different eyes to which they see the aortic annulus. And so you expect to have different measurements across these imaging modalities.
Intuitively, I suppose a 3D structure probably would benefit from a 3D analysis, so perhaps CT should top two-dimensional echocardiography and angiography, and that's, I presume, what we saw in this study, confirming findings from prior studies.
Right. So, initially we were sizing transcatheter valves using echocardiography, and we saw enormous rates of paravalvular leaks. Up to 10 to 30% of patients back in the late 2000s were experiencing significant PVL. In 2010 and onwards, the community started to use CT for sizing, and CT is able to, like you say, appreciate the 3D nature of the aortic valve annulus, and better able to select a valve type and size for a particular patient. So we've seen now in the last, I would say, several studies, whether you look at the Boston Scientific, Symetis, Portico, CoreValve, Edwards, all of their CE mark trials or large registries or randomized trials are all showing a significant reduction in PVL rates of anywhere from 2 to 10% with respect to significant PVL, and this is mostly attributed to the use of CT. So if we go back to this manuscript, what did they find? Well, your echocardiography always appreciates the minimum diameter of the aortic valve annulus, whereas when you look at angiography, which looks at the patient from anterior to posterior, as opposed to echocardiography, which is looking from left to right from a parasternal long axis view, the angiography gives you a larger diameter, typically the maximum diameter.
How does the CT perform? So
the CT is able to pick up both of these parameters. So it picks up the minimum diameter from echo, and it picks up the maximum diameter from angiography. So when you look at the trend across imaging modalities, you see that echocardiography measured the smallest diameter, and the angiography measured a larger diameter, but CT in the end always measured the largest diameter when you look at the maximum diameter. And when you get the perimeter derived or the area derived diameter, it falls somewhere close to the angiography measured diameter.
So the CT perimeter diameter probably gives us the largest diameter if we compare CT mean diameter or CT area derived diameter, because of the fact that the annulus is very often elliptical, and as we increase our ellipticity, the relative size of the area reduces compared to the perimeter.
Right.
That's what they found in this study?
Correct. Yeah, so they, that in their discussion, they point to the fact that when you size something based on perimeter, it may be a more constant variable across patient subsets. It may lead to more consistent sizing because as you take an annulus and you squeeze it and make it more elliptical, let's say, you're decreasing its area, but you can maintain the perimeter relatively constant. So they did suggest that perimeter is probably a more stable parameter for sizing. But in this paper, one of the limitations is that they did not correlate these findings to clinical outcomes.
Okay. So this was a technical study comparing 3 different modalities, suggesting that CT and indeed CT perimeter gives us perhaps the most reproducible, the most consistent and largest diameter, and lessons of how to apply this information to our clinical practice.
Right. So there was 2 major points that weren't discussed that are in fact very important. One, it's the acquisition of CT data, and second is the interpretation and application of the findings to the clinical scenario. So although they did measure the intra-class, the intra-observer and intra-observer variations, there's a little bit more to it than just 2 people agreeing on the measurement. It's actually taking that measurement and then applying it correctly for that particular patient. So again, it's the acquisition of the CT data, which is not always easy. This is a major pitfall across many centers, and it's the understanding of how to apply the data once you obtain it.
Okay. So thanks for that, Nick. I think a very interesting paper by the Byrne group. Important findings that have relevance to how we size patients. But going forward, I think what you suggest is that we need to apply those measurements into individualized valve size selection.